Hello, good afternoon. This is the cataract session now. It's going on. I think you are ready with all your presentations, and you have to adhere to the time we have given, 4 minutes for each presentation. And now we start the session. I request Dr. Deepak Chaudhary, who is going to present on the presentation of traumatic cataract in a tertiary eye care center of coastal Odisha. Where is Dr. Deepak Chaudhary? If it is not there, then we'll go for the second one. Dr. Manpreet Kaur, who is going to present a case of isolated unilateral coloboma of lens. Dr. Manpreet Kaur. Okay. The third one, Dr. Sunita, who is going to present on the comparative evaluation of longitudinal ultrasound pulse, burst, OSIL, and OSIL LP mode of phacoemulsification.
So good morning to the chair and the audience. My topic of presentation is a comparative evaluation of longitudinal ultrasound pulse and burst mode with the OSIL and the OSIL IP, that is the intelligent phaco modes of phacoemulsification. So now one would think why this study is being conducted. It is being conducted because not all the machines have the OSIL and the OSIL IP or the elliptical modes of phacoemulsification. But the burden of cataract, as we know, is a huge burden. So not every machine has that modulation, so we need to know what is best for the machine, for us, that is available in the machines. So the study was conducted to compare the efficacy of traditional longitudinal with the torsional modes of phacoemulsification in terms of cumulative dissipated energy, ultrasound time, effective fluid used, endothelial cell count post-operatively, and the best corrected visual acuity. It was a hospital-based randomized controlled prospective study with a total of 240 cases divided into 4 study groups. Pre-operatively, best corrected visual acuity and grade 4 dense nuclear cataracts according to the LOX3 grading system were included, and the endothelial cell count was done by specular microscopy. Infinity vision system was used with the uniform settings of 0.9 mm, 30-degree bevel, 20-degree bent Kalman macro tip with a vacuum of 350 to 450 mm Hg and aspiration fluid rate of 45 cc per minute. The irrigation bottle height was 110 centimeter. The power settings used in different groups were for group A, that was the longitudinal pulse mode, was 60% power with a 50% UT cycle of 6 milliseconds on and 6 milliseconds off with a total of 83 pulses per second. Group B was longitudinal burst mode with 60% power and a burst width of 35 milliseconds with subsequent off time to 0. Now, Group C was continuous OSIL with 100% amplitude linear torsional power, and Group D was intelligent phaco OSIL with 100% amplitude torsional power with a 10 millisecond longitudinal pulse when 95% vacuum is reached, and the ratio of longitudinal to torsional was 1:1. Intraoperatively, the incision was of 2.8 mm standard incision with a quick chop with technique was used for phacoemulsification of the cataract, and the cataract grade was confirmed at the time of chopping the nucleus into 2 halves rather than simply relying on the visual estimation pre-operatively. The parameters recorded intraoperatively from the matrix were cumulative dissipated energy, ultrasound time, effective fluid used, and post-operatively parameters recorded on day 1, day 3, day 7, and day 30 were endothelial cell count and best corrected visual acuity. So the results were the mean CD, the ultrasound time was least in the longitudinal burst mode compared to all the other modes and was highest in the continuous OSIL mode. The effective fluid used was least in the longitudinal pulse mode compared to all the other modes. So this is a bar diagram for the same, and post-operatively, there was no significant change in the endothelial cell count and BCVA in all the 4 groups. So to conclude, the burst mode is the most efficient ultrasound phacoemulsification in terms of CD and ultrasound time, as CD, ultrasound time, and EFU are the most direct measures of its efficacy. Burst modality is used only when required, whereas in longitudinal pulse and continuous torsion with or without IP, there is significant measurable wastage of the initial energy, or there's loss of energy as it is repeatedly or continuously being used, even when it is not required. In torsional phaco, though the energy dissipated is only 4.4 in comparison to the longitudinal ultrasound, However, it has to be used in the continuous mode and with high power settings of 80 to 100%, whereas in longitudinal mode, the power used is only 50 to 60%, thereby explaining the difference in the CD and the ultrasound time in the results. So though intraoperatively CD and ultrasound is significantly lower in the burst mode compared to other modes, however, it does not affect the postoperative visual recovery, thereby emphasizing the relevance of the technique in phacoemulsification. Thus, it is the surgeon and the technique which ultimately influence the final outcome of phaco in surgery rather than anything else. Thank you.
Good, very nice. One thing I would like to tell you, you are a postgraduate, is it not? Are you a postgraduate student?
Senior
No.
resident.
Huh?
Senior resident.
Okay, so one thing is don't crowd your slides like
Slides,
this,
yeah,
and don't type in all capital letters, and it makes everything looks the same. You know, so highlight points and then so that it's a 4-minute presentation. So you have to get the maximum out of your slides. That is, the slides are marked here. So, and then I have presented a similar paper around 20 years back, or maybe 15 years back or something. But then, with your endothelial cell count, how long did you follow up endothelial cell count?
So 30 days. 30 days.
30 days is very low to compare endothelial cell, but that's okay. But if the endothelial cell count is not bad, then this CD actually does not correlate anything to clinical stuff. But then good that you have used less energy in this one. So if properly used, energy little more doesn't matter actually. But well done.
So it might not matter in a healthy cornea, but it may affect the poor endothelial count cells. Like,
Come again.
so it
No,
might
speak
not
to the
have-
mic, speak to
sorry.
the mic.
So it might not have mattered in these cases because they were all healthy corneas with the normal endothelial cell count pre-operatively. But for cases wherein we have poor endothelial cell count or there's poor corneal health, these modulations might give us some better results.
Yeah, definitely. When CD is less, it's better.
Yes.
Good.
Thank you so much.
Okay, we'll go for the next presentation. Dr. Kanika Bharadwaj is available. Dr. Kanika Bharadwaj. Any previous presentation, Dr. Deepak Chaudhary or Dr. Manpreet Kaur, please come. You are a second presenter, no? Please come. She is going to present a case of isolated unilateral coloboma of the lens.
A very good morning, everyone. I'm going to present a case of isolated unilateral coloboma of lens. Coloboma word is derived from the Greek word koloboma, meaning mutilated, curtailed, or with defect. Lens coloboma probably results from a localized absence of lens zonules, leading to flattening of equator in the region of zonular defect due to lack of tension on the lens capsule, which may lead to subsequent contraction and notching. The term lens coloboma is thus a misnomer. It can occur in isolation or with other colomatous condition of globe. It is generally unilateral but can be bilateral also. Coloboma of lens can be divided into typical coloboma, those that occurring at the site of embryonic fissure, or atypical, not at the site of embryonic fissure. A 60-year-old male presented with gradually progressive, painless diminution of vision in left eye from last 1 year. There was no history of diabetes, trauma, and family history was non-contributory. The systemic examination was unremarkable. Ocular examination revealed a vision of 6/36 in right eye and PLPR in left eye. Intraocular pressure was 16 and 15. On dilated ocular examination, the patient had immature senile cataract in right eye and mature cataract with temporal lenticular coloboma from 2 or to 4 o'clock position. There was no associated iris coloboma or choroidal coloboma on B scan. The left eye keratometry values were 44.5 diopters at 180 degree and 43.5 at 90 degree. Axial length was 22.83. IOL power was calculated to be 21.5 diopter. The patient underwent SICS with rigid PCI implantation. On first post-op day, slit lamp examination showed a well-centered and stable IOL in the capsular bag. The patient gained best corrected visual acuity of 6/6. This is the how the patient looked like. Lens coloboma generally results from failure of fetal fissure closure during ocular development, generally unilateral. Once the zonule or ciliary body fails to develop, tension is released and the lens contracts segmentally a notch. Lens coloboma appears in combination with other ocular defects including iris, choroid or optic disc coloboma. Apart from ocular defect, lens coloboma can be one of the manifestations of systemic diseases like Marfan syndrome or Marshall syndrome. The embryologic genesis of atypical coloboma is uncertain. A number of theories propose a rotation of embryonic fissure, inflammatory process or persistent of vascular mesodermal tissue that blocks the forward growth of neuroectoderm. Treatment is mainly surgical. The surgical management is challenging as there is high risk of capsular fornix aspiration, zonular dialysis extension, vitreous herniation in anterior chamber, IOL decentration and closure of capsular opening. This case report is a rare presentation of isolated unilateral temporal coloboma without any iris abnormality and posterior segment coloboma or any other ocular or systemic anomaly and had a good postoperative outcome. More studies investigating the etiology of isolated lens coloboma and postoperative long-term results of eyes undergoing cataract surgery are required. Thank you.
Could you just go back to this picture, the photograph of that case? You had shown
Yes.
one slide, no? Yeah, yeah. Okay.
Can it be colored as a coloboma? Coloboma is
See,
actually,
sometimes in a
it will
trauma,
not look like this. Yeah.
long-standing trauma and
Yes,
loss of zonules, and the equator may get straightened out.
Yeah.
Can look like that, but then this is a slightly absorbed kind of look, which is going inside also. Possible, but then that other possibility also has to be kept in mind. And otherwise, there was no other zonular weakness anywhere else. No, no. So it's again a straightforward thing, but then good. We have to mature cataracts and all. We have to dilate and see before that is another
That is
point which we have to keep in mind. And we may not show any phacodonosis, but
Again, your slides very crowdy. Okay, it is very difficult to read from this place. Sir is looking back and reading that one. Okay, nice case.
Thank you, sir. Thank you so much.
We'll go the next presentation. Any? So I call Dr. Kanika Bharadwaj. You know there. Then Dr. Muhammad Afroz Alam is going to present on impact of surgical volume on intraoperative complications in manual small incision cataract surgery.
Good afternoon, everyone. So my topic for today is the impact of surgical volume on intraoperative complication in MSICS. So first, why there is need of volume surgery and why we did this study. So globally, there is estimated 596 million people is suffering from distance visual problem with 43 million people blind. That means having vision less than 3/60. Of this 43 million, almost 50% is due to cataract. And if we see the Indian scenario, India shares almost quarter of the blind population of the worldwide. And recently, high volume cataract surgery has evolved as an approach to clear the cataract backlog. And especially in Bihar, which lacks in effective cataract surgical rate coverage, national average for the cataract surgery per million people is almost 6,000 to 7,000, while in Bihar there is a 2,600 per million population. Cataract surgical rate is 2,600 only. So, and most of the cataract surgeries are conducted in winter season only. There is misbelief that one should not get operated in summer season and harvesting season. So many hospitals has to tackle a lot of volume during winter seasons. That's why volume surgery becomes necessary to tackle the cataract backlog. In Akhand Jyoti, we annually perform more than 90,000 surgeries. So, and 2/3 of these surgeries were usually performed in winter season only from October to February. There are many studies that have shown the annual volume and surgical complication rate, but there is paucity of articles on daily volume. There are few studies one study from Arvind in 2005 and from Nepal in 2022, which have shown favorable result in high volume cases, but there is lack of studies from northern part of India, especially from Bihar. So we did, with this in mind, we did this study. We have compared the high volume versus low volume complication rates and also the surgeon's experience. We have not included any surgeon who is less than 2 years of volume surgery experience, and we have categorized surgeons into 2 categories, 2 to 5 and more than 5 years of volume surgery experience. We did this retrospective study we have taken data from the hospital EMR. Eligibility criteria were only those surgeries which were purely MSICS, not those who were converted to MSICS and was FACO, planned as FACO was included, and any difficult cases like pseudoexfoliation, hypermature cataract with lax zonule, lens-induced glaucoma, these were not included. So total 11,763 surgeries were included, and in high volume we did almost 7,832, and low volume 3,831 surgeries. 59.3% were male and 40% were female, and overall complication rate was 2.06%, which is almost similar to the other studies, but in higher volume cases, complication was rare, 1.72%, then 2.14% in lower volume, with odds ratio of 2.05%. And most common complication was PCR with vitreous loss. Second most common was zonular dilysis. If you see the surgeon's experience, even with the lower experience, higher volume days were having lesser complication, fewer complications than lower volume days, with odds ratio of 2.86%. If we see the surgeon's experience also. And so high volume surgeries have completely lesser complication rates. So experience of surgeon can reduce complication rates in both high volume and low volume. And as we have seen from the WHO World Vision Report, to increase the cataract surgical coverage by 30% by 2030, so institution by adopting the high volume surgery can help eliminating needless blindness from the cataract. So thank you.
That's okay. Your study shows it is a less complication
Yes,
compared to other one. So why?
We had two limitations. One was in low volume days the patient age was more, so that can be the one of the reasons. Second reason is in high volume days workflow is more efficient. Surgeon is more focused, and maybe the less complicated cases or less complicated cases are posted for that surgeon who is doing high volume, just to make him do faster or something.
Yeah,
Yes.
because you have categorized experienced and less experienced.
Yes, sir.
But you have not taken the age as a criteria.
Yes.
Okay. So, anything?
Yeah, in 2005, you were mentioning about Arvind paper. I was in Arvind in
Yes, sir.
2005. So good that you have presented from North India also. See, the thing is, I want one clarification. What 50 per day and more than 50, that is single surgeon or multiple surgeons?
No, sir. For single surgeon, 50 per day
Single
is
surgeon,
considered.
50 per
We
day
have
or-
considered.
No,
Arvind has
actually
considered-
NPCB, I think it is not more than 20.
So I think 25 per room may be allowed.
May be allowed.
If you are doing in 2 rooms, maybe. But anyway, this is good that you are because you have divided them into. This is how we also do. Higher volume days, we select regular cases, normal cases, and higher volume, higher experienced surgeons who can do faster without complications, and post, as you said, the pseudoexfoliation, small pupils and all those on a different day with the lesser number, so that they can spend more time and reduce the complication rate during that also. So that is the way it has to be done, and you people are under stress to do in the winter season. That is also true.
Yes.
I realized that when I went the first time to Rajasthan in 2004 or something, And then I realized that that is the time we do, otherwise we cannot do it. But it is not there in South, it's not like that. Every day we can do. So, otherwise, good, please carry on the good work you are doing.
Thank you, sir.
I have one question.
Yes, sir.
You said that if you are operating more number of the cases, you are more concentrating. If you are operating, say, since morning 8 o'clock, and you are operating 50 cases, as you said, don't you feel in the last phase you get lethargic or something like that? And
Sir,
you
usual duration of surgery is 2 to 3 minutes. So
2
if
to
we
3
get
minutes
gap
in
in between, we
SICS.
get irritated. Yes, sir.
2 to 3 minutes. I have yet to see, I have seen blue menthol also operating. 2 to 3 minutes cataract surgery with IOL is a dream. I don't think practically somebody can do in 2 to 3 minutes. I have never seen.
Sir, my one video is getting published next month. That is less than 2 minutes surgery.
2 minutes.
Yes, sir. 1 minute and 30 seconds, 1
minutes,
minute
no.
15
It
seconds.
will be around
And results are better because
24
we
is an average number.
do minimal manipulation inside the entry chamber. So results are even better. Next day cornea is quite clear.
Fantastic.
Yes, sir. Thank you, sir.
Okay, good. Next, I call Dr. Prajakta Dandekar. She is going to present on retropupillary iris claw lens implantation in novice surgeon, a video-based retrospective analysis.
Hello. Good morning, everyone. I am Prajakta Dandekar from Shantila Sangvi Eye Institute. I am practicing cornea there. So my presentation is on retropupillary iris claw lens implantation amongst novice surgeons. So the background goes like because cataract surgery is the most common surgery in ophthalmology, but it has a learning curve, and to combat this learning curve, what we have done. So we have FACO development programs which were introduced by Alcon team. Then there are SICS training programs which various teaching institutes. Then there are IMAS training in which they have different models and even animal models in which you can study. And there is Help Me See in which there is simulation-based training for cataract, SICS as well as FACO. But what about the complications? Do we have any training for complications? No, we directly handle them on the table. So this study was to identify the difficulty which were faced by novice surgeons in retropupillary iris claw lens implantation and streamline the surgical steps by providing guidelines. So this was a retrospective study. We analyzed 17 videos which we operated in September 2023 to June 2024 by 4 novice surgeons. Novice surgeons were defined as surgeons who were efficient in doing cataract surgery. They have done more than 1,000 cataract surgeries, but they were not very trained in iris claw lens implantation. Less than 5 iris claw lens implantations have been done by them in early days. So the outcomes were measured as follows. These were the 14 parameters which were analyzed as primary outcome, and secondary outcome was considered as visual acuity, IOP and CME was documented. So the 14 parameters I'll explain one by one. So our results were the side port construction was our first parameter. So in iris claw lens implantation, we know that the side ports have to be at 180 degrees because the IOL haptics are at 180 degrees. So if when there are primary, when the surgery is done as a primary surgery, like the cataract surgery along with the iris claw lens implantation, generally the cataract side ports go at 10 and 2, and in iris claw you need at 180. So that was a difficult point, and if the additional side ports are not made, then the surgeons were struggling for this step. Then the second parameter was tunnel construction. So 100% tunnels were constructed in a 3-planar configuration. Then third parameter was triamcinolone acetonide, whether it was used. So 3 patients it was used, and all the 3 patients did not show any rise in IOP in the post-operative period. But one patient, the triamcinolone dye has gone behind the IOL, so there was difficulty in vision because of the dye. The second, the fourth point was whether PI was done. So 8 patients underwent peripheral iridectomy, and in 8 patients it was not done, and 1 patient had an iris defect. Then ACM was used mainly by the surgeon who was a posterior segment surgeon. So 7 cases were done using ACM, and 10 patients were in 10 cases ACM was not used. And anterior segment surgeons, 10 cases were performed by anterior segment surgeons and 7 cases by posterior segment surgeons. So minimum time taken was 23 minutes, maximum was 100 minutes. 100 minutes because mostly combined cases were also included here, because the posterior segment surgeon in which he has done IOL, in which the late bag in subluxation was there in the posterior segment. The enclavation instrument, the most common enclavation instrument used was enclavation rod. The other instruments were 27 gauge cannula, iris repositor and Sinskey hook. And enclavation rod was found to be better because with other instruments there were cases of iris defects seen, and with multiple attempts were used instead because of the other instruments not able to enclave the haptic into the iris. And the other points were medial enclavation and circular pupil. So if you see this diagram on the right side, so this is a pictorial representation of the iris. So the sphincter pupillae muscle is at the pupillary margin, and dilator pupillar muscle is just behind it in the ciliary zone. So beyond the collarette, near the contraction furrows, if the enclavation was done, it was shown that the pupils were circular, and if there is medial enclavation, that is the enclavation was done medial to the collarette, then there was peaking of the pupil. So we found that the peak pupil was present in almost 9 cases, and in which medial enclavation was done. So haptic exposure was present in 3 cases, and IOL was subluxated intraoperatively in one of the cases, which was again reposited, and one case because of iris atrophy, it was subluxated. So it was secondary outcome. So 20/30 vision we got in 5 cases, and vision was 20/40 and 20/100 in 10 cases. Most common cause of decreased vision was glaucoma, corneal scar, diabetic macular edema, CME, post VR surgery for retinal detachment, full thickness macular hole, and epiretinal membrane. So these are the surgical steps which we streamlined, that we should mark the incisions, side port incisions at 180 degrees. They should be stab incisions with less intracorneal tunnel. And if TA is used, it should be used diluted so that it doesn't hamper the vision in the postoperative period. And PI should be mandatory. In our cases also, we got three patients who had raised IOP, in which one case was treated medically and 2 patients had to undergo PI by YAG laser. And removal of viscoelastic should be done behind the IOL, which could also be the reason of pupillary block. And hammer forceps should be pointing towards the haptic, which which helps in easy enclavation. And enclavation instrument should be as thin as possible to avoid iris trauma. So our conclusion was that iris claw lens implantation has a learning curve and requires analysis of surgical videos for optimal outcomes. So eyes undergoing repeat surgeries are prone to multiple complications affecting the final visual outcomes. Thank you.
Any comment?
Yeah, I think you're aware that it is a 4-minute presentation, is it not?
Yes.
If you too much overshoot, no, your marks will come down. Okay, so any presentation can be made according to the time. If you are given 8 minutes also, the same thing can be presented. 4 minutes also, same thing. So that is one thing you should be careful when you present the competitive sessions.
Yes.
And PI not done in 8 cases or something.
Yes,
PI not done, how can it be a learning curve issue? Why have they not done a PI?
So because iris claw has 3 designs. So one is a biconvex design, one is a concavo-convex design, and one is a plano-convex design. So plano-convex design was a design which was used for anterior placement of the iris claw, and the other designs which were biconvex and concavo-convex, they were used for when the iris claw was used in the posterior segment, like when it was.
This included both, huh? This included anterior
No,
and
this
posterior.
included the iris claw, which was posterior placement. So in posterior placement, sir, PI with many studies, sir, which we followed. So PI has not been mandatory for posterior placement of iris claw. It was mandatory for anterior placement, in which the plano-concave lenses were used.
Anyway, I don't use iris claw lenses, but I have heard people telling that the PI is a good thing to do.
Yes.
Otherwise, fine. This is an easy thing to do. This was all secondary, or there were primary cases also?
Primary also.
Primary also?
Yes.
Or primary only?
No, both were there.
All are primary?
Yes, both were there. Mixed, sir. It's a posterior segment surgeon who got late in the back subluxation IOLs and all. So they are mostly secondary, and very few cases were primary. So 3 cases were primary out of 17. Mostly it were retina complications were there in most of the cases. So mostly all these cases have been operated by the posterior segment surgeons or in combination with anterior and posterior segment.
Have these novice people tried this procedure in wet lab?
We haven't looked at that data.
I think we should teach them in
Yes.
wet lab 3 or 4 cases so that
Yes.
they know exactly all these steps and then get the feel
Yes.
of how to enclave and all.
Yes,
It's easy to do in wet labs.
Yes, sir.
Thank you.
Okay, thank you, Ma. Next, we'll call Dr. Neeraj Agarwal, who is going to present on comparative analysis of optical biometry, lensometer versus IOL master in silicon oil filled globe.
A very good afternoon to my judges and all. So my paper is the comparative analysis of optical biometer, LensStar versus IOL master in silicon-filled eyes. As we all aware that a silicon-filled tamponade is commonly used as an adjunct for vitreoretinal surgery, and success in visual improvement following cataract surgery in such cases depends upon the axial length measurement and the precise IOL power calculation. So the purpose of the study was to analyze the biometry result in a post-vitrectomized silicon-filled eyes that underwent phacoemulsification. As we know that IOL master uses the partial coherence interferometry to measure the axial length, whereas the LensStar based on the optical low coherence refractometer. And both the biometers provide the high resolution non-contact measurement of the ocular biometry. It measures the axial length in the visual axis and both measures accurate axial length in the silicon-filled eyes. It was a retrospective non-randomized case series where 82 silicon-filled eyes underwent uneventful clear corneal phacoemulsification with IOL implantation and silicon vial removal. The study was conducted between Jan 23 to March 2024 in Disha Eye Hospital, India. And the intraocular lens power was calculated using the SRKT formula targeting for ametropia. The post-operative refraction was performed in a span of 1 to 3 months. The mean absolute post-operative refractive error was analyzed both in terms of the preoperative axial length and the type of retinal surgery. This is the graphical representation of the axial length, where the mean axial length in the both category was comparable. This is an absolute post-operative refractive error, where the axial length was further divided into less than 24 mm and more than 24 mm, and the both groups, the mean axial length was found to be comparable. The absolute post-operative refractive error in terms of the type of the surgery, the pars plana vitrectomy or pars plana vitrectomy with skull buckling, both the groups, the mean, absolute post-operative refractive was comparable in both groups. In terms of the percentage of the refractive error, it was divided into less than 1 diopter, between 1 to 2 diopter, and more than 2 diopter. In all the 3 groups with the 2 biometers, the results were comparable. Looking at the literature, there was a paucity, and almost I didn't find any study where the 2 biometers was compared, particularly for the silicon-filled eye. There are the few studies where they have done a study where there is a mixed group for the pseudophakic, aphakic, and silicon-filled eye. The study was done by the Casper Rosser et al. And he has done a prospective study with a sample of 144 size with small subset of 14 silicon-filled eyes. And they found that the measurement with the LensStar correlated well with the IOL master in cataract, pseudophakic, aphakic, and silicon-filled and the normal eyes. To conclude, the refractive outcome in both groups were similar irrespective of type of surgery and the method of biometry. LensStar and IOL master showed a good correlation for the axial length measurement in silicon-filled eyes. And finally, the optical biometry, LensStar or IOL master are comparable and reliable in silicon-filled eyes. Thank you.
Thank you, Neeraj. Did you do all these in silicon oil mode or regular mode?
In the silicon-filled mode.
How does it make a difference in these? If you put in silicon oil mode, what changes in the machine? What is the change they are doing in silicon oil? What is the change which can happen when light goes in this fast, this small length? How does it differ?
There's a slowdowns that,
But
normal
thing is,
biometry you could go with
slowing down, ultrasound slowing down is fine. But the speed of light, the speed of light and the size of the eyeball. I was always wondering, but anyway. And the refractive error residual, which you said comparable, but you had 1 diopter, 2 diopter and all
Yeah,
those.
that was divided into all the 3s.
That's right. That is similar in groups is fine. But why did you get this kind of 2 and all?
That's what we
These are the highest end machines which can be used for calculating the IOL power.
Yes, sure.
Both are comparable. But then there are cases which
There are
had
cases
two
where
diopters and all.
surprise was more. I mean, there was the refractive error was more than 2 diopter also, we get that.
But that should not happen, no, with this kind of thing. What do you think it would have been?
I mean, cannot pinpoint that.
Anyway,
why
So
the
in that-
refraction was
and
there,
formula, why did you use SRKT when all these had Barrett's easily available in that?
that was, we are used to that SRKT.
Try using Barrett, because I was seeing the refractive error residual and you have used the SRKT. Please try it, it's free in both these machines. So please try to use the Barrett and see, you'll get better outcomes. Good, thank you.
And that one is, how many cases they get, -1, -2, -4?
That numbers are
That
not clear.
numbers you are not clear.
That numbers are not clear.
Okay, that's also not clear. Because once we know the number, then we can say which one is better and which one is not better.
Okay. sir.
Okay?
Okay.
Okay, nice, my.
Okay, we have one more next paper by Dr. Ankit Ahir. Dr. Ankit is here? No. Okay, next one, Dr. Anusha Rajendran. Dr. Anusha Rajendran, not here. Okay, then Dr. Charu Sagar, not here. And then last, Dr. Manu Priya. So she'll present on effect of ND-YAG laser posterior capsulotomy on refraction, IOP, and macular thickness. First two presenters who are not there, Deepak Chaudhary has come? No. Deepak Chaudhary has not come. And second, Dr. Sunita is also not here, no? Fourth one, sorry. Kanika Bharadwaj. Yeah, she is not there.
Good afternoon, everyone. The topic for my presentation is effect of amount of energy used in ND-YAG laser posterior capsulotomy on refraction, intraocular pressure, and macular thickness. So basically, posterior capsular opacification is the most common late complication of cataract surgery by means of any ECC procedure. And it usually occurs, it can even be per-op PCO, but it usually occurs between 1st to 5th years post-operatively in about 7 to 31% of patients. And usually we see the incidence that is reported around 10% at the end of 1 year, 20% at the end of 2 years, and 30% at the end of 3 years. The reason for occurrence of capsular opacification is the continued viability of lens epithelial cells. Now, there are factors that affect PCO formation that include age, history of intraocular inflammation, presence of pseudoexfoliation syndrome, size of the rhexis, cortical cleanup, capsular fixation of the implant, design of the lens implant, modification of the lens surface, and time elapsed in surgery. Prolonged use of post-operative topical corticosteroids or NSAIDs do not seem to play a role in the rate of PCO formation. PCO is now routinely treated by the ND-YAG laser capsulotomy with significant visual improvement in most cases. Now, laser capsulotomy uses a quick pulsed ND-YAG laser to apply a series of focal ablations in the posterior capsule and thereby creating a small circular opening in the visual axis. Although it is a relatively effective and safe procedure, laser capsulotomy may cause complications including transient intraocular pressure elevation, hyphema, uveitis, CME, and retinal detachment. Apart from this, mechanical effects can occur such as pitting of the IOL, dislocation of IOL into the vitreous, and shift in the position of IOL. Explanations for the rise in IOP following ND-YAG laser capsulotomy include deposition of debris in the trabecular meshwork, trabeculitis, neurovascular mechanisms, pupillary block, and inflammatory swelling of the ciliary body or iris root. This procedure also causes a change in the position of the implant, which can cause a change in the effective power of the lens in the eye and potentially alter the refraction of the patient. Macular edema occurs due to the movement and damage in the vitreous cavity and release of inflammatory mediators due to damage of the blood aqueous barrier. The aim of the study was to study the effect of amount of energy used during ND-YAG laser posterior capsulotomy on the refractive status, IOP, and macular thickness. This was a prospective observational hospital-based study which was carried out over a period of 6 months in a tertiary care center. Patients were presenting to the OPD within the given time period and fulfilling the inclusion criteria were included in the study. So only the cases that had undergone uncomplicated manual SICS or phaco with PCL implantation in the back were included. Exclusion criteria were any complications occurring during the surgery, glaucoma, cornealopasties, retinal diseases, uveitis, optic neuropathy, and any active ocular inflammation. Total 72 eyes were included in the study. Detailed history and a preoperative examination was done. Patients were divided into two groups on the amount of energy used. In group A, less than 50 millijoules of energy was used, and group B, more than 50 millijoules. And the eyes were anesthetized using paracaine, and a capsulotomy size of 3 mm or more was considered adequate. Post-operatively, the patients were given moxifloxacin 0.5% plus dexamethasone 0.1%, and patients were examined at 1 hour, 1 week, and 1 month post-procedure. Now, in group A, the total mean energy used was 24.48, and in group B was 76 millijoules. And according to the age and male to female ratio in both the groups was similar in both the groups. And as we can see, the BCVA had increased significantly from the pre-procedure level at both 1 hour, 1 week, and 1 month post-operatively. And the difference between the two groups was insignificant. There was a significant rise in IOP in both the groups at 1 hour, 1 week, and 1 month. However, at 1 month, the IOP returned to preoperative levels in group A, but it did not return to preoperative levels in group B. There was a significant difference. And same goes for central macular thickness. It increased, but in group A, it decreased to preoperative levels at 1 month, and it did not decrease to preoperative levels. There was a significant difference in group B. So the reported incidence of PCO is around 20% at 2 years and 28.5% at 5 years. And the most common complication of Nd:YAG laser posterior capsulotomy reported is increased IOP. In the absence of any anti-glaucoma or anti-inflammatory prophylaxis, around 59 to 67% of patients showed IOP increment. Despite the prophylactic treatment, increased IOP has been reported in around 15 to 30% of patients. However, in a few studies, they have reported no increase in IOP at all. Another similar study by Eri et al. Divided the groups according to the energy used as less than 80 millijoules and more than 80 millijoules, and they reported similar outcomes. Now, Findle et al. Reported a subtle posterior shift of the PCIOL occurring along with deepening of the interior chamber. However, in other studies, they failed to observe this effect. Ari et al. Also noted significant increase in the macular thickness following Nd:YAG laser posterior capsulotomy, and the increment was higher in patients who received higher energy. In the present study, we noticed significant change in BCVA post-procedure. There was transient increase in IOP in group A, which returned to pre-procedure level at 1 month. However, they did not return to pre-procedure level in group B. Limitations of the study are small sample size, less duration of follow-up, and potential IOP rise due to topical steroids was not taken into account. Also, the type of PCO was not taken into account. So to conclude, the IOP rise in macular thickness increase is higher with higher energy. However, it may not always necessitate any medications. Thank you.
Because no other presenter, we allowed you. You have taken almost six minutes. Not followed the
Sorry.
4 minutes. Okay, anyhow, we'll.
No. Are you a postgraduate student?
No, sir, I'm a senior resident.
Huh. And why did you use an antibiotic steroid combination in this post-YAG? Please
Sir,
don't. Just give
Okay.
steroid
Okay,
if you
sir.
want to give steroid. Huh? Maybe their
So that
hospital
was the
gives it like that.
I
and
had
so-
this study I had done when I was a postgraduate resident, 3rd year.
No, you should question existing rules even
Yes,
as a
sir.
postgraduate resident. Okay. So
Definitely.
next thing is why would hyphema be a complication in if you do a proper capsulotomy?
Sir, like any complication, like if we injure the iris in some case.
So some cases they would have hit the iris also.
No, it didn't happen, but it is
Possible.
it is a
Anyway, so
possible
please focus only on the
complication.
capsule.
Ye-
And
yes, sir.
otherwise, this is a age-old thing which has been being told from ages, capsulotomy and its complications and all those.
So the basic thing was
Good.
like, do we need to give anti-glaucoma and NSAIDs post procedure or not? So as you can see
Your significant rise in IOP is 13, from 13 to 15, 13 to 16 and all
yes, sir,
those.
but the p-value is coming as
That's what.
significant,
So
that's why.
p-value and clinical correlation is something which you should understand.
Yes,
We should
sir.
all take into consideration. P-value may be high, but when
Huh.
you say clinically somebody's IOP going from 13 to 16 and coming back to 15,
Huh.
which are all clinically very,
Very-
irrelevant things.
yes,
But
sir.
then still, keep all those in mind. When you present that it is a significant thing, it has to look significant also.
Yes, sir.
But otherwise, good.
Thank you, sir.
Okay, thank you very much. Anybody? Dr. Chowdhury? And the third one is Dr. Kanika Bharadwaj. If they are not there, then we'll conclude the session, sir. Thank you. Please come all the presenters for a photo session.
Who is collecting this? Come. You got to put all this in the cover. Total